In this chapter, we will be discussing blood. Blood is the internal transport system of the body, and it's very important to know about blood because understanding the anatomy and physiology of blood helps you to advise patients on activities to prevent blood clots during hospital stays once you all become clinicians. We're going to cover a lot of different modalities of blood. We're going to talk about what blood does, what it's made of, and when we talk about what it's made of, we're going to take a closer look at the blood plasma and the formed elements, which consist of the erythrocytes, the leukocytes, and the platelets. And then we're going to look at what happens when a blood vessel breaks. We are going to look at how to replace blood in an emergency situation and what the study of blood can tell us about a patient. We're going to discuss the different blood types and blood transfusions. And then finally, we're going to discuss the developmental aspects of blood. There are three main functions of blood, which include transport, regulation, and protection. And here we're going to talk about each one of these functions individually. So transport has to deal with delivering oxygen and other nutrients throughout the body to the body cells. The transport of metabolic waste to the lungs and kidneys is essential for elimination from the body. And the blood also helps to transport hormones from endocrine glands to target organs. When we've mentioned regulation, regulation is a function which includes maintaining body temperature by absorbing and distributing heat where necessary, maintaining the normal physiological pH using different buffers. There's an alkaline reserve of bicarbonate ions, for example, and also maintaining adequate fluid volume in the circulatory system. And blood also serves as a protective mechanism. The plasma proteins and platelets in blood initiate clot formation. If you're bleeding, you need the blood to clot so that you don't bleed out. And the blood also helps to prevent infection because there are agents of immunity carried in the blood, and these agents include antibodies, complement proteins, and white blood cells. Blood is the only fluid tissue in the body. It's a type of connective tissue, and the matrix is a non-living fluid called plasma, which you can see in the top half of the test tube on the far right-hand portion of the screen depicted in yellow. The plasma is 55% of the whole blood, and it's the least dense component of the blood. There are cells that are found in the blood, and in the living blood cells are called formed elements. The formed elements consist of erythrocytes. They're also known as red blood cells or RBCs. The leukocytes, also known as the white blood cells or WBCs, and the platelets. And these cells are suspended in the plasma. So in order to separate out the plasma and the different types of cells in the blood, you would do what's called centrifugation, which is a high-speed spin. You put the whole blood, you withdraw the blood from the vein, and you put the blood in a test tube. You put it in a centrifuge, which is going to vortex and spin the sample at a very fast speed, and that will separate the components of the blood into the plasma and the formed elements, and it also put this little white layer in the middle called the buffy coat. In the test tube, you're going to see the erythrocytes. They're going to form on the bottom, and an important physiological number to know in the clinic is the hematocrit, and hematocrit can tell you a lot. The hematocrit is the percent of blood volume that is the red blood cells. And normal values in males are approximately 47%, give or take 5%, and in females, 42%, give or take 5%. When you do this centrifugation separation, you're going to find the white blood cells and the platelets in the buffy coat, that white layer that I mentioned earlier. And again, the plasma is going to be found on top, as indicated by the yellow consistent layer. Here we're going to talk about some physical characteristics and the different volumes of blood that exist between males and females. Blood is a sticky, opaque fluid which has a metallic taste to it. And the color of blood varies with the oxygen content. So whether or not the blood is oxygenated or deoxygenated is going to slightly change the color of it. So blood that has high oxygen levels shows a scarlet red. So it's going to be a little bit lighter red color. And blood that is low in oxygen levels shows a very dark red color. The physiological pH of blood should be between 7.35 and 7.45. Please pay close attention to this pH value here because that will be a test question. Your blood makes up approximately 8% of your body weight, and there is a volume difference between males and females. Males do typically have a little higher blood volume than females. On average, the blood circulating through the male body will be between 5 and 6 liters, while it'll be a little less in the females. It'll be between 4 and 5 liters in the females. The blood plasma is a straw-colored sticky fluid, and it consists of approximately 90% water. In the blood plasma, you can find over 100 different types of dissolved solutes. These include nutrients, gases, hormones, wastes, proteins, and inorganic ions. Of those, the plasma proteins are the most abundant solutes, specifically albumin. The plasma proteins are going to remain in the blood. They're not taken up by the cells, and the proteins are produced mostly by the liver. The liver is responsible for producing albumin, which makes up 60% of the plasma protein. And the function of albumin is to be a carrier for other molecules. It also serves as a blood buffer, and it contributes to the plasma osmotic pressure. This slide here puts all of the elements I mentioned on the previous slide into a table for you. And the table continues on to the next slide. So please take a minute to review this table here. As I mentioned, this is a continuation of the table from the previous slide. So these are more components of the plasma. And just take a minute to review these as well. So as we mentioned previously, there are many different components of blood cells, and there are several different types of blood cells. On this slide, we're going to talk about the formed elements, which again consist of the RBCs, the red blood cells, the WBCs, the white blood cells, and the platelets. Please note that only the white blood cells are complete cells. The red blood cells do not have a nuclei or other organelles, and platelets are merely cell fragments. Most of the formed elements survive in the bloodstream for only a few days, and most blood cells originate in the bone marrow and do not divide. So here's a photomicrograph of a human blood smear using what's called a Wright stain at a very high power magnification, a 610x magnification. You can see some of the formed elements. You can see the fragmented platelets. You can see the erythrocytes with the pale center, so they don't indicating that they don't have a true nuclei. You can see some of the cells that are involved in the immune response and inflammation. You'll see the neutrophils, you see the eosinophils, monocytes. Later on, I'm going to teach you this little mnemonic called, which says, never let monkeys eat bananas. And the N stands for neutrophils, the L stands for lymphocytes, the M stands for monocytes, the E stands for eosinophils, and the B stands for basophils. And this mnemonic goes down in descending order from the cells that should be most prevalent in the blood, being the neutrophils, to the cells that should be least prevalent in the blood, being the basophils. And we're going to talk about the roles of each one of these cells specifically later on. The structural characteristics of erythrocytes are unique to themselves. As we mentioned, erythrocytes are also called the red blood cells. They're very small in diameter. They're approximately 7.5 microns, and they serve a very important role in gas transportation throughout the systemic circulation. They have a biconcave disc shape. You can see this depicted in the lower portion of the picture here, which is basically formed because they are anucleate. They don't contain a true nucleus. They essentially also don't have any organelles such as the mitochondria or the Golgi apparatus. However, the erythrocytes are filled with hemoglobin, and the purpose of them being filled with hemoglobin is for gas transport. And they contain many different types of plasma proteins. One in particular, called spectrin, provides flexibility to the erythrocyte to allow it to change shape as it's moving through the systemic circulation. And the erythrocyte has three main features that make it really efficient for gas transportation. First of all, we mentioned the biconcave disc shape, and what this does is offers a huge surface area relative to the volume for gas exchange. Furthermore, it has a high amount of hemoglobin in it, which makes up approximately 97% of the cell volume, and this 97% doesn't include water. And as I mentioned, the lack of organelles. The red blood cells do not have mitochondria, and ATP, or adenosine triphosphate production, is anaerobic, so they don't consume oxygen, any of the oxygen that they transport. The RBCs are dedicated to respiratory gas transport, and hemoglobin binds reversibly with oxygen. We mentioned the importance of the hemoglobin content and that the hemoglobin content in males and females differs a little earlier in the lecture. Again, the normal values for amount of erythrocytes between males and females differs as well. As you have a different hemoglobin content, you should suspect that the normal value, the amount of erythrocytes found in the males and females would also differ. In males, we're going to find between 13 and 18 grams per 100 milliliters of blood, and in females, you'll find a little bit less. You'll find about 12 to 16 grams per 100 mils of blood. Hemoglobin consists of red heme pigment bound to the protein known as globin. And globin is composed of 4 polypeptide chains. You can see in the picture here, you can see the heme group, you can see the alpha globin chains and the beta globin chains. So hemoglobin does have 2 alpha and 2 beta globin chains. And the heme pigment, which is bonded to these chains, gives blood its red color. And each heme's central iron atom binds to one specific oxygen molecule. Each hemoglobin molecule has the capability to transport up to 4 oxygen molecules. And when there are 4 oxygen molecules bound to one hemoglobin molecule, the hemoglobin is said to be fully saturated. Each red blood cell contains approximately 250 hemoglobin molecules. And the red blood cells aid in oxygen loading in the lungs, oxygen unloading in the tissues, and also CO2 loading in the tissues as well. Erythrocytes, as well as all the other different types of blood cells, are formed through a process called hematopoiesis. And this occurs in the red bone marrow. The red bone marrow is composed of reticular connective tissue and blood sinusoids. The hematopoietic stem cells, also known as the hemocytoblasts, are stem cells that give rise to all different types of formed elements. And these are committed cells. Once they are pre-programmed to differentiate into a specific type of cell, they cannot change. So in the production of erythrocytes, there are 8 main stages which contribute to the ultimate formation of the erythrocyte. So starting with the hematopoietic stem cell, also known as the hemocytoblast, that cell will differentiate into what's called a myeloid stem cell. The myeloid stem cell will then transform into the proerythroblast. The proerythroblast is going to divide many times and then transform into basophilic erythroblast. The basophilic erythroblasts are responsible for synthesizing ribosomes, and they'll stain blue. From the basophilic erythroblast, the formation of the polychromatic erythroblast occurs. The polychromatic erythroblasts are responsible for synthesizing large amounts of the red-hued hemoglobin, and now the cell, if you stain it, is going to show both pink and blue areas. From the polychromatic erythroblast, comes the orthochromatic erythroblast, and this contains mostly hemoglobin, so they just appear as pink when you stain them. And they eject most organelles, the nucleus degrades, and this causes the concave disc shape to begin to take formation. Next, the reticulocyte will form, and this still contains a small amount of ribosomes. However, as this differentiates into the mature erythrocyte, in approximately 2 days after the differentiation, the ribosomes will degrade and the reticulocyte will transform into a mature red blood cell. And important to note here is that the reticulocyte count indicates the rate of red blood cell formation. So if you're having if you have a high reticulocyte count, that indicates that the red blood cells are forming. There may be a high content of red blood cell in the blood, or they may be forming at an accelerated rate, which can be indicative of many different types of pathologies. So as in any physiologic event in the body, homeostasis has to be maintained for adequate and proper function. So what happens if there's too few red blood cells? What can that cause in the body? That'll lead to a condition called tissue hypoxia, where the tissues aren't getting the amount of oxygen that they need. What happens if there's too many red blood cells present? This can lead to an increased blood viscosity and make blood more difficult to travel throughout the body, and this can elevate blood pressure, lead to systemic hypertension and conditions similar to that. More than 2 million red blood cells are made every second, and the homeostatic balance really depends on the production and destruction of proper hormonal controls and a proper dietary content. One of the main hormones that plays an essential function of the formation of red blood cells, as we mentioned earlier, is erythropoietin. There always has to be at least a small amount of erythropoietin in the blood to maintain a proper basal rate. This is released by the kidneys and in some form the liver in response to tissue hypoxia. So what happens in the body if the body has low oxygen levels, there are oxygen sensitive enzymes in the kidney cells that can't degrade a specific factor called hypoxia-inducible factor, also known as HIF or HIF. If HIF is not being degraded, it's going to accumulate, and that's going to trigger the synthesis of erythropoietin. And erythropoietin can also cause hypoxia. The decreased number of red blood cells can be due to several factors such as hemorrhage or internal increased destruction. Insufficient hemoglobin in each red blood cell is going to cause systemic disruption. For example, if you have global insufficient hemoglobin per red blood cell, you may get iron deficiency anemia. And the erythropoietin has to be regulated properly when you're moving in different geographical locations as well. As you move higher in altitude, you're going to have a reduced availability of oxygen present. So if you don't have proper regulation of erythropoietin, and if you don't have proper systemic production of the red blood cells, you may develop lung problems such as pneumonia and altitude sickness if the erythropoietin controls are not well maintained and well regulated. Now let's take what we've learned and apply it to a clinical situation. When we have a homeostatic imbalance of erythropoietin, how can that develop in the first place? Erythropoietin is a substance that's very commonly abused by athletes. A famous case that many of you may have heard of was the blood doping accusations against the famous cyclist Lance Armstrong. Athletes abuse erythropoietin because what that does when athletes take in erythropoietin, it increases the hematocrit level, and that allows the athlete to increase stamina and overall performance. And when they looked at Lance Armstrong's erythropoietin levels, they were through the roof, and that could really explain why he had the Superman capabilities that he did. However, please note that there aren't only beneficial aspects to blood doping. There are many, many dangerous consequences. The erythropoietin can increase the hematocrit level from 45% up to even 65%, which is a very dangerous level. This can lead to dehydration and concentrating blood even more, and can really disrupt systemic blood flow. The systemic blood flow can be disrupted because the blood becomes like a sludge, and it can cause unnecessary clotting, which could lead to stroke, could also lead to heart failure, which could ultimately lead to death. So there are many dangerous consequences to blood doping with erythropoietin. As I mentioned earlier, there are many specific dietary requirements for proper erythropoiesis to occur. You must have an adequate intake of amino acids, fats or lipids, carbohydrates, and iron as a whole. You can get iron from your diet. You could also get iron from a vitamin supplement. And iron is essential because 65% of iron is found in hemoglobin. The rest of the iron in your body can be found in the liver, throughout the spleen, and in your bone marrow. Iron is a very interesting element in itself, as the free iron ions are toxic, so iron has to be bound with some type of protein. Iron is stored in our cells in a form known as ferritin and hemosiderin, and then it's transported in our blood bound to a protein in the form of transferrin. Many other vitamins are necessary for homeostatic balance. One and two in particular are vitamin B12 and folic acid. These are necessary for DNA synthesis and for rapidly dividing cells, such as the developing red blood cells. As we move in to talk about the life cycle of the red blood cells, I want you to know that the lifespan can fluctuate, but it is approximately between 100 and 120 days from birth of the red blood cell to destruction of the red blood cell. And as we mentioned before, they are anucleates, so they can't synthesize their own new proteins. They don't have a nucleus to compact all the information and undergo DNA synthesis, so they cannot grow, they cannot divide, and they have this predetermined lifespan of approximately 100 to 120 days. As the red blood cells mature and become older, they become very fragile. And as they become very fragile, different components start to degenerate. One essential component that starts to degenerate is hemoglobin. And when the hemoglobin degenerates, the red blood cells can get trapped in the smaller circulatory channels, especially in the spleen. And when they get trapped in the spleen, the macrophages will migrate to these trapped red blood cells, and they'll begin to engulf and break down the dying red blood cells. So when the red blood cells are being broken down, the heme, the iron, and the globin molecules are separated. The iron is going to bind to ferritin or hemosiderin, and is going to be stored in the body for reuse. Heme is going to be degraded into a yellow pigment known as bilirubin. Bilirubin is secreted from the liver in the form of bile into your intestines, where it is degraded to the pigment urobilinogen. Urobilinogen is transformed into a brown pigment called stercobilin that leaves the body in the feces. Globin is metabolized into amino acids and then released into the systemic circulation. As we move into discuss the erythrocyte disorders, most of the disorders can be classified into two general categories. They can be classified as anemias, having too little red blood cell content, or polycythemias, having too many red blood cells present. What happens in most cases of anemia is that the blood has an abnormally low oxygen carrying capacity that is too low or inadequate to support normal metabolism. The patient may present to the clinic with symptoms of fatigue, pallor, dyspnea, and chills. And as we go to talk about the different subcategories of anemia, they can be grouped into three main categories based on their cause. We're going to discuss the anemias associated with blood loss. We're going to discuss the anemias associated with not enough red blood cells being produced. And we're also going to discuss the types of anemias that are associated with too many red blood cells being destroyed. Anemia can be due to blood loss. And here we're going to talk about what can cause hemorrhagic anemia and chronic hemorrhagic anemia. So when you see hemorrhagic anemia, this may be presenting in a patient who is coming into the emergency room who just experienced a car crash. The patient may have a severe wound or several severe wounds where blood is just systemically leaking out of the patient. The main aim for treatment is to get the blood back into the patient as fast as possible via blood transfusion. As we shift gears a little bit, we'll talk about chronic hemorrhagic anemia, which there is not an extreme blood loss, but there's a slight and persistent chronic blood loss. For example, this can result from hemorrhoids or an internal bleeding ulcer. The primary problem must be treated to stop blood loss. Anemia can also arise when there are not enough red blood cells being produced. When there are not enough red blood cells being produced, this can result in a condition called iron deficiency anemia. This can be caused by hemorrhagic anemia, but is most likely caused by low iron intake or impaired iron absorption. The red blood cells that are being produced in a patient with iron deficiency anemia are called microcytes. They're called microcytes because they're small and pale in color, and they cannot synthesize hemoglobin because there's a lack of iron. And what the clinician will do for the patient is to simply treat the patient with iron supplements. Pernicious anemia, also known as Addison's anemia, is an autoimmune disease that can result when there are not enough red blood cells being produced. And what happens in pernicious anemia is that the autoimmune disease begins to start destroying the stomach mucosa that produces intrinsic factor. Intrinsic factor is vital to absorbing vitamin B12. B12 is needed to help the red blood cells divide, and without proper B12 absorption, the red blood cells are going to have a very difficult, if not impossible, time to divide, which would result in large macrocytes. And what the clinician would do is simply give B12 injections. B12 could also be given through a nasal gel. Pernicious anemia could also result from a low dietary intake of B12, and this could be a problem for vegetarians, as B12 is not really a main component of their diet. In renal anemia, what's happening is there's not enough red blood cells being produced because of a lack of erythropoietin. Erythropoietin is produced in the kidneys, as we mentioned before, and in renal disease, the kidneys are dysfunctional, so the kidneys cannot produce enough erythropoietin to keep up with the body's systemic demand. What the clinicians will do in forms of treatment is to give the patient synthetic erythropoietin. Aplastic anemia can arise when there is a destruction or inhibition of the red bone marrow. As we mentioned earlier, red bone marrow is the site for erythropoiesis. So if there's destruction of this, the RBCs can't generate in the first place. This can be caused by numerous factors, including drugs, chemicals, radiation, or viruses, but unfortunately the cause is usually unknown. And in aplastic anemia, all formed element cell lines are affected. And not only does this result in an anemic condition, but this can also give rise to clotting and immunity deficits. What the clinician will do in terms of treatment, in terms of the short-term treatment, the clinician will give blood transfusions that will allow blood with proper amounts of red blood cells to be transfused into the patient. And in the long term, again, this is still in the experimental stages, and there still needs to be a improvement in terms of treatment for long-term aplastic anemia. But what clinicians are doing right now is they are doing transplants with stem cells. When there are too many red blood cells being destroyed in the body, conditions known as hemolytic anemias can arise. Sometimes there's a premature lysis of the red blood cells. The body is recognizing that the red blood cells are misshapen and not functional, so for whatever reason, and the macrophages will go to these dysfunctional RBCs and begin to degrade them. And this can be caused by a multitude of reasons. For example, an incompatible transfusion, transfusing blood with the wrong blood type could cause this. That could also be a very detrimental condition. So whenever there are blood transfusions occurring, it is of vital importance for the clinician to make sure that the blood types are compatible between the person who is receiving the transfusion and the person who is donating the blood. The hemolytic anemias can also be caused by systemic infections. And many cases of hemolytic anemias are genetically inherited. Further on in the lecture, we're going to talk about the thalassemias, which are genetically inherited conditions where the body is making an abnormal form or an inadequate amount of hemoglobin, and sickle cell anemia, which again is another type of genetically inherited condition where the red blood cells are not able to adequately carry oxygen throughout the body, and the red blood cells become rigid and sticky, and then they get shaped, like you can see in the picture here, like sickles or crescent moons. And we're going to discuss the physiology of what can happen in the body systemically when the thalassemias and sickle cell anemias arise. Thalassemias are a form of genetically inherited conditions that can arise when there are too many red blood cells being destroyed. The thalassemias are typically found in people of Mediterranean ancestry and descent. And as we mentioned, the hemoglobin molecule has the different globin chains. And if there's a globin chain absent or faulty, this can give rise to the thalassemia, and this is how they're classified. They're either alpha thalassemias or beta thalassemias. And what happens systemically is the red blood cells become very thin and delicate, and they become deficient in hemoglobin. And there are many subtypes that range in severity from mild to very extreme. And the very severe cases may require monthly blood transfusions in order to keep the patient alive. Sickle cell anemia is another genetically inherited condition that can arise when there are too many red blood cells being destroyed. What happens is the genes that regulate hemoglobin formation become mutated. The hemoglobin S gene specifically is mutated. And what happens is there's only one amino acid that gets disrupted in the entire globin beta chain of 146 amino acids, yet this can cause the disease to arise. And what's happening with the red blood cells is they are sickling, and the sickling can cause the blockage of blood flow. And the red blood cells become this crescent-shaped or this sickled shape when oxygen levels are low. For example, during exercise. So people with sickle cell anemia have to really modulate and be very conscientious of the amount that they exercise and the intensity of their exercise. And the misshaped red blood cells, they rupture very easily, and they can occlude and block small blood vessels. And this could lead to many different conditions such as stroke, heart failure. And what happens to the patient is the patient gets very poor oxygen delivery throughout the body, and the patient will constantly complain of fatigue and pain throughout the body. Sickle cell anemia is highly prevalent in Black people of the African malarial belt and their descendants. One of the possible benefits of having one of the genes associated with sickle cell anemia mutated is that having one gene and not having full-blown sickle cell anemia confers resistance to malaria. Now, it doesn't make the person completely immune to malaria, but it does give resistance against malaria and contracting the disease. And as you know, malaria is transmitted to the person via the Anopheles mosquito of endemic African regions. Malaria is a very devastating viral disease as it kills nearly 1 million people each year. People with 2 copies of the hemoglobin S gene that are mutated develop the sickle cell anemia, while those with only 1 copy mutated of the hemoglobin S gene confer the resistance to malaria. And individuals with only 1 copy, they do display some of the anemic symptoms, but they, as I mentioned, they have a better chance of surviving malaria. Unfortunately, those affected by sickle cell anemia will undergo treatment for the entire lifespan. Any type of acute crisis that may arise is usually treated with blood transfusions or inhaled nitric oxide. And as I stated, this is a lifelong illness that has to have constant maintenance. And basically what the main goal of treatment is focused on is to prevent the sickling of the red blood cells. So the patient may be given a drug known as hydroxyurea, which induces the formation of fetal hemoglobin, which doesn't sickle. And there are many experimental therapies going on right now in forms of stem cell transplants, different gene therapies, and different delivery mechanisms of nitric oxide for vasodilation. Although there are clinical studies showing promising results, there is still no cure for sickle cell anemia currently. On the opposite end of the spectrum from the anemias are the polycythemias. And in polycythemia, there are too many red blood cells present. And what this does is increases blood viscosity throughout the body and leads to a sluggish blood flow. In polycythemia vera, this is basically a bone marrow cancer that leads to excessive production of red blood cells. And the hematocrit may go as high as 80%. And the main therapeutic treatment as of now is therapeutic phlebotomy. There's another condition that can arise due to abnormal excessive production of red blood cells, and this is called secondary polycythemia. And secondary polycythemia is caused by low oxygen levels when somebody may be at an elevated altitude that they're not used to. Secondary polycythemia can result. Or whenever there's an increased erythropoietin production, which could lead to an excessive amount of red blood cells being produced. That can also lead to secondary polycythemia. Leukocytes, also known as white blood cells or WBCs, are the only formed element that is a complete cell with nuclei and organelles. As we mentioned, these are very different from the red blood cells, which are anucleate and do not contain organelles. The leukocytes make up a little bit less than 1% of the total blood volume. And there are approximately 5,000 to 11,000 white blood cells per microliter of blood. The main purpose and function of the leukocytes is to function in defense against disease. And they can do this by leaving the capillaries through a process called diapedesis. So the leukocytes can actually migrate out of the capillaries, go wherever in the body they need to go, and help attack whatever systemic pathogen may be in the body. They move through the tissue spaces by a motion called amoeboid motion, and they also use what's called positive chemotaxis. So they use chemical signals to help direct them to where they need to go. A condition that can arise when there are too many white blood cells being produced is called leukocytosis. And this is when there's a white blood cell count over 11,000 per microliter. And although a normal increase in leukocytes is a normal response to an infection, excessive and prolonged leukocytosis is something that should be closely monitored. Leukocytes can be grouped into two major categories. They can either be classified as granulocytes or agranulocytes. The granulocytes contain visible cytoplasmic granules, while the agranulocytes do not contain the visible cytoplasmic granules. And there are several different subtypes of leukocytes. We have our neutrophils, we have our eosinophils, basophils, lymphocytes, monocytes, and there's a little mnemonic to help you remember the different types of leukocytes from decreasing abundance. So this mnemonic is never let monkeys eat bananas. So N stands for neutrophils, L stands for lymphocytes, M stands for monocytes, E stands for eosinophils, and B stands for basophils. So, and the neutrophils, they are going to be the most prevalent leukocyte in the blood. They comprise 50 to 70% of the cells that you're going to find as white blood cells. Then the lymphocytes are agranulocytes, remember, and they comprise approximately 25 to 45% of the white blood cell content. And then we have the monocytes, which comprise approximately 3 to 8%, the eosinophils 2 to 4%. You will see an increase in eosinophils in allergic reactions, which we are going to talk about in the immune system. And then basophils should be the least abundance, only 0.5% to 1% abundance as total white blood cell content. Here's a very nice picture showing and classifying the different types of granulocytes and agranulocytes. Let's begin by talking about the granulocytes, the neutrophils, the eosinophils, and the basophils. The granulocytes are larger and they're shorter lived than the red blood cells. They contain lobed rather than circular nuclei, and the cytoplasmic granules stain specifically with Wright stain. And all of the granulocytes are phagocytic to some degree. As we mentioned in the previous mnemonic, never let monkeys eat bananas, the neutrophils are the most numerous white blood cells, and they account for 50 to 70% of them. They're about twice the size of the red blood cells, and the granules stain with both acidic and basic dyes. The granules contain either hydrolytic enzymes or antimicrobial proteins known as defensins. Neutrophils can also be called polymorphonuclear leukocytes, or PMNs for short, because the nucleus is lobular, and the cell can have anywhere from 3 to 6 lobes. Neutrophils are very phagocytic. They're referred to as the bacterial slayers of the immune system. They kill microbes by a process called the respiratory burst. And what happens during the respiratory burst is the cell synthesizes potent oxidizing substances such as bleach or hydrogen peroxide and uses those against whatever pathogen may be present in the body. Here's a zoomed in picture of a Wright stain of an eosinophil. Eosinophils account for 2 to 4% of all the leukocytes, and the nucleus, as you can see in this picture, consists of 2 lobes that are connected by a broad band, which kind of resemble a pair of earmuffs. The red staining granules that you see in the picture contain digestive enzymes, and they release these enzymes on large parasitic worms, which basically help to digest their surface and destroy the worms. They also play an important role in allergies and asthma, as well as immune response modulation. The basophils are the rarest form of WBCs that you'll find in a normal peripheral blood smear, as they account for only 0.5% to 1% of all the leukocytes found in the body. The nucleus stains a deep purple with 1 to 2 constrictions. And as you can see in the picture, there are a lot of large purplish black basophilic granules that contain histamine. Histamine is an inflammatory chemical that acts as a vasodilator and attracts white blood cells to inflamed sites. And the basophils are functionally similar to mast cells, which also release histamine. Depicted here is a lymphocyte, also known as an agranulocyte. The agranulocytes lack the visible cytoplasmic granules that are seen in the granulocytes, such as the neutrophils and the eosinophils and basophils. There are two types of agranulocytes. There's the lymphocytes, which are depicted here, and the monocytes, which we'll talk about in a minute. And both of them have a spherical or kidney-shaped nuclei. The lymphocytes are the second most numerous white blood cells that are found in the body, as they account for approximately 25% of the WBCs. They are large, they stain dark purple, they have circular nuclei with a thin rim of blue cytoplasm. And they're mostly found in the lymphoid tissue. For example, they're found in the lymph nodes and the spleen, but a few actually do circulate in the blood. The lymphocytes are very, very crucial to immunity, and there are two specific types of lymphocytes that we're going to talk about more specifically in the immune chapter. We have the T lymphocytes, also known as T cells, which act against virus-infected cells and tumor cells, and we have the B lymphocytes, also known as B cells, which give rise to plasma cells, which help to produce antibodies to fight systemic disease. The monocytes are the largest of all the leukocytes, but they only comprise approximately 3 to 8% of the content of the white blood cells. They have an abundant pale blue cytoplasm, they stain dark purple, and they have this U or kidney-shaped nuclei, as you can see in the picture here. Monocytes have the capability to leave the circulation, enter tissues, and differentiate into macrophages. I always keep the M's together. Monocytes, macrophages. Monocytes have the capability of differentiating into macrophages, which have phagocytic capabilities, which help to engulf pathogens and prevent disease. The monocytes are actively phagocytic cells, and as I mentioned, they're very crucial against viruses, bacterial parasites, and preventing chronic infections. And they activate lymphocytes to help mount an immune response in case the body is being attacked by any specific pathogen. Leukopoiesis is the production of white blood cells, which are stimulated by two types of chemical messengers from the red bone marrow and mature WBCs. The two types of chemical messengers are interleukins, which are numbered IL-1, IL-2, IL-3, 4, 5, so on and so forth, and colony stimulating factors, also known as CSFs. And they are named for the white blood cell type that they stimulate. For example, the granulocyte CSF stimulates granulocytes. All the leukocytes originate from hemocytoblast stem cells that basically branch into two distinct pathways. We have the lymphoid stem cells and the myeloid stem cells. The lymphoid stem cells, as the name implies, they produce lymphocytes, and the myeloid stem cells produce all of the other elements. This chart is a nice schematic representation of leukocyte formation. It depicts how the granulocytes and the agranulocytes are produced and formed. So if you look on the left side, we see the myeloid stem cell, which give rise to the granulocytes. And if you look on the far right side of the picture, we see the lymphoid stem cells, which give rise to the agranulocytes. I just really want you to know the differences between the granulocytes and the agranulocytes. Don't worry too much about the differentiation and all these minor names, but I do want you to pay close attention to the lymphocytes on this slide. I want you to know that the T lymphocyte precursors give rise to immature T lymphocytes that mature in the thymus. I remember the T and T, just as we did the M&M mnemonic for monocytes can form into macrophages. T lymphocytes mature in the thymus, so T and T. And then the B lymphocyte precursors give rise to immature B lymphocytes that mature within the bone marrow, so B and B. B lymphocytes mature in bone marrow. And then the lymphocytes live from a few hours to a few decades. So just take a minute to review this chart and be sure that you can tell and know how to classify the cells which fall under the classification of granulocytes versus those that fall under the classification of agranulocytes. Bringing all this into a clinical perspective, many of the hematopoietic hormones such as EPO and CSFs are used clinically. They can be used to stimulate bone marrow of cancer patients receiving chemotherapy or stem cell transplants, and they are also used to increase the protective immune responses of patients who have been diagnosed with HIV and AIDS. The leukocyte disorders can be categorized into two broad categories, one being an overproduction and the other being too low of a production or an inadequate production. So as we talk about the overproduction of abnormal white blood cells, if this is occurring, this can give rise to different types of leukemias and a condition known as infectious mononucleosis, which we will discuss further in a little while. If you have an abnormally low white blood cell count, this can give rise to a condition known as leukopenia. Leukopenia can be drug-induced, particularly by anti-cancer drugs or glucocorticoids. Leukemias are cancerous conditions which involve an overproduction of abnormal white blood cells. And leukemias usually involve clones of a single abnormal cell. And they're named according to what abnormal white blood cell clone is involved. For example, the myeloid leukemia involves the myeloblast descendants, and the lymphocytic leukemia involves lymphocytes. Leukemias can be categorized and classified in many ways. One of the ways they are classified and categorized is based on their clinical presentation, whether they are acute, meaning they're quickly advancing, or they are chronic, they're slowly advancing. The acute form of leukemias are derived from stem cells, and this primarily affects children. However, the acute leukemias can be seen throughout the lifespan. On the other hand, the chronic or the slow advancing leukemias involves the proliferation of later cell stages, and these are more prevalent in the elderly, although they can arise at any time throughout the lifespan. Without treatment, all leukemias are fatal. Basically, what is happening is there's immature, non-functional white blood cells flowing through the bloodstream, wreaking havoc on the body. The cancerous cells fill the red bone marrow, and they crowd out the other cell lines that should be present there. And when they crowd out the other cell lines, this leads to anemia and abnormal bleeding. And death usually results from internal hemorrhage or overwhelming infections. And although there are cures for certain types of leukemias, not all leukemias are curable. Some treatments that are being used are irradiation, anti-leukemic drugs, and stem cell transplants. And hopefully one day research will lead us to find a cure for all types of leukemias. Infectious mononucleosis is another type of leukocyte disorder, and this is a highly contagious viral disease, more commonly known as the kissing disease, and is caused by the Epstein-Barr virus. And what happens in infectious mononucleosis is there are high numbers of typical agranulocytes that become present in the body. And it involves lymphocytes that become enlarged, and originally it was thought that the cells were monocytes, so the disease was originally named mononucleosis. When a patient presents to the clinic, the clinician may observe symptoms of general fatigue and tiredness, achiness throughout the body, chronic sore throat, as you can see in the picture of what's inside the oral cavity may look like in a patient who has contracted infectious mononucleosis, and a low fever. And the best thing to do is just rest and stay away from everyone. There's nothing really more you can do other than rest and stay hydrated, intake adequate fluids and vitamin C, and the virus usually resolves itself and runs its course within 4 to 6 weeks. Platelets originate from the hematopoietic stem cell, just like many other cells do, and they are essentially cytoplasmic fragments of the megakaryocytes, this stage 4 differentiation that you can see in the picture here. Platelets have a blue staining outer region and purple granules, and the granules contain several different things. They contain the neurotransmitter serotonin, they contain calcium ions, they have enzymes, ADP, and platelet-derived growth factor. All of these components of the granules, they aid in the clotting process. And normally, you'll see approximately 150,000 to 400,000 platelets per milliliter of blood. And like I said, platelets are essentially fragments of a larger megakaryocyte. And the main function of the platelets is to form temporary platelet plugs to help seal any breaks in blood vessels. And platelets are constantly circulating through the bloodstream throughout your body, and the circulating platelets are kept inactive and mobile by nitric oxide and prostacyclin from endothelial cells lining the blood vessels. Platelets age very quickly and they degenerate in about 10 days. Hemostasis encompasses the fast series of reactions for stoppage of bleeding, and hemostasis requires clotting factors and substances to be released by platelets and injured tissues. There are 3 main steps involved in hemostasis, and we're going to cover them in the upcoming slides. Step 1 is the vascular spasm, step 2 is the platelet plug formation, and step 3 is the coagulation or the blood clotting. The first step in the hemostatic process is the vascular spasm. The vessels are going to respond to an injury by doing what is called vasoconstriction. The diameter of the vessels is going to become smaller. And vascular spasms are triggered by several different entities. They can be triggered by a direct injury to the vascular smooth muscle. They can be triggered by chemicals which are released by endothelial cells and platelets. And they can also be triggered by pain reflexes. And the vascular spasms are most effective in the smaller blood vessels, and they can significantly reduce the blood flow until other mechanisms kick in. Step 2 of hemostasis is the platelet plug formation. Platelets stick to collagen fibers that are exposed when the blood vessels are damaged. The platelets do not stick to the intact vessel walls because there is no exposure of collagen. Also, the prostacyclins and nitric oxide secreted by endothelial cells act to prevent the platelet sticking. Von Willebrand factor is a clotting factor that helps to stabilize platelet collagen adhesion. When activated, the platelets begin to swell and they become spiked and sticky, and they release chemical messengers such as ADP, serotonin, and thromboxane A2. ADP causes more platelets to stick and release their contents, while serotonin and thromboxane A2 enhance the vascular spasm and platelet aggregation. There's a positive feedback cycle that begins to initiate when the platelet plug begins to form. As more platelets stick, they release more and more chemicals, which cause more platelets to stick and release more chemicals. So the platelet plugs are fine for small vessel tears, but larger breaks in vessels need an additional step. The additional step that is needed is known as coagulation. This is the actual step where the blood is clotting. And coagulation reinforces platelet plug formation with fibrin threads. And blood clots are effective in sealing the larger vessel breaks. So blood is transformed from liquid to gel via the process of coagulation. And there's a series of reactions that use clotting factors known as procoagulants, which are mostly plasma proteins. And they're numbered 1 to 13 in the order of which they were discovered. Please note that vitamin K is needed to synthesize 4 of these factors. And now we're going to talk about coagulation in 3 distinct phases. Here we're going to talk about the 3 phases of coagulation. Coagulation occurs when the intrinsic and the extrinsic pathways usually work together and form a clot. These intrinsic and extrinsic pathways are triggered by tissue damaging events. And they involve a series of procoagulants, and each pathway's cascades ends with the activation of factor 10. Factor 10 then complexes with calcium ions, PF3, platelet factor 3, and factor 5 to form the prothrombin activator. The intrinsic pathway is called the intrinsic pathway because clotting factors are present within the blood intrinsically. The intrinsic pathway is also triggered by negatively charged surfaces such as activated platelets, collagens, or even a glass of a test tube. The extrinsic pathway is called the extrinsic pathway because there are factors needed for clotting which are located outside of the blood, or extrinsically. The extrinsic pathway is triggered by exposure to tissue factor, or TF, which is also known as factor 3. The extrinsic pathway bypasses several steps of the intrinsic pathway, so it is actually a little bit faster of a pathway. Phase 2 of the coagulation pathway is known as the pathway to thrombin. Here, prothrombin activator catalyzes the transformation of prothrombin to activate the enzyme thrombin. And in phase 3, this is known as the common pathway to the fibrin mesh. Here what's going on is thrombin converts soluble fibrinogen to fibrin. The fibrin strands form the structural basis of the clot. Fibrin causes the plasma to become a gel-like trap which catches the formed elements. And then thrombin, along with calcium ions, activates factor 13, which is known as the fibrin stabilizing factor. The fibrin stabilizing factor does several things. First, it cross-links fibrin, and then it strengthens and stabilizes the clots. This is a really nice scanning electron micrograph of erythrocytes trapped in the fibrin mesh, which I talked about on the previous slide. So as it is just important for when there is a bleeding episode for a clot to form, the clot also must be stabilized and removed when the damage has been repaired. Here we're going to talk about what clot retraction and fibrinolysis are. So the clot retraction is when the blood clot begins to dissociate and break down. What happens here is actin and myosin in the platelets contracts within 30 to 60 minutes, and the contraction pulls on the fibrin strands, squeezing serum from the clot. Serum is the plasma minus the clotting proteins. And what that does is it draws ruptured blood vessel edges together. The vessel is healing even as the clot retraction occurs. And one of the main factors that contributes to this healing is platelet-derived growth factor, or PDGF. And this is a growth factor that's released by platelets in order to stimulate the division of smooth muscle cells and fibroblasts to rebuild the blood vessel wall. Another important factor is VEGF, or vascular endothelial growth factor. And VEGF stimulates endothelial cells to multiply and restore the endothelial lining. And finally, fibrinolysis occurs. This is the process whereby the clots are removed after the repair is completed. And this begins within 2 days and continues for several days until the clot is fully dissolved. As the name implies, fibrinolysis is the breakdown of fibrin, which is one of the main components of the clot. Plasminogen, a plasma protein that is trapped in the clot, is converted into plasmin, which is a fibrin digesting enzyme, which helps, again, to break down the fibrin. And then tissue plasminogen activator, or TPA, is also known as factor 12, and thrombin, they all play a role in this conversion process. There are 2 limiting factors that mediate the limitations of the clot size. First, swift removal and dilution of the clotting factors, and second, inhibition of activated clotting factors. There's a limited amount of thrombin which is restricted to the clot by fibrin threads, and preventing the clot from getting too big or escaping into the bloodstream is essential for the clot to function and form properly. Antithrombin 3 inactivates any unbound thrombin that escapes into the bloodstream, and heparin, which is found in the basophils and mast cells, inhibits thrombin by enhancing antithrombin 3. Furthermore, factors that prevent proper platelet adhesion can limit the clot growth or formation. Examples of this could be the smooth endothelium of the blood vessels preventing the platelets from clinging to it, the endothelial cells secreting antithrombic substances such as nitric oxide and prostacyclin, and vitamin E quinone, formed when vitamin E reacts with oxygen, is another potential anticoagulant. When we talk about the disorders of hemostasis, the disorders can be categorized into two major types of disorders. We have the thromboembolic disorders, which result in undesirable clot formation, and we have the bleeding disorders, which result in abnormalities that prevent normal clots from forming in the first place. And then we have a condition called disseminated intravascular coagulation, or DIC. And DIC involves both the thromboembolic disorders as well as the bleeding disorders. So when we categorize different thromboembolic conditions, they are classified based on whether or not we see a thrombus or an embolus. Thrombi and emboli are plural for thrombus and embolus. A thrombus is a clot that develops and persists in an unbroken blood vessel, as you can see in the left side of the picture. Thrombus and thrombi may block the circulation and can cause tissue death to occur. Emboli are when the thrombi are freely floating in the bloodstream. And I'm sure you have all heard of the term embolism. An embolism occurs when an embolus obstructs a vessel, such as in the pulmonary or cerebral circulation, there may be pulmonary emboli or cerebral emboli that obstruct the bloodstream and blood circulation, which could result in a stroke and ultimately death if not treated in a timely fashion. There are many risk factors that contribute to developing thromboembolic conditions, such as atherosclerosis, inflammation, slowly flowing blood or blood stasis from immobility, and smoking. For treatment for the thromboembolic conditions, anticoagulant drugs are usually used, and these drugs are used to prevent undesirable clotting from occurring in the first place. Some of the drugs are mentioned here on this slide. Aspirin is an antiprostaglandin that inhibits thromboxane A2. Heparin is an anticoagulant used clinically for pre- and post-operative cardiac care. Warfarin, or Coumadin, is used for people prone to atrial fibrillation, and warfarin interferes with the activation of vitamin K. And dabigatran directly inhibits thrombin. A condition known as thrombocytopenia can occur when there are deficient numbers of circulating platelets in the systemic circulation. The patient may present with what's called petechiae, which are small hemorrhages from suppression or destruction of the red bone marrow. This can be caused by numerous conditions such as malignancy, radiation, or drugs. And if a patient presents with a platelet count of less than 50,000 per microliter, this is diagnostic criteria for thrombocytopenia. And to treat these patients, the medical doctor will usually give a transfusion of concentrated platelets. Because this is a platelet deficiency, giving a concentration of platelets should elevate the total platelet count. Bleeding disorders can also arise because of impaired liver function. If the liver is unable to synthesize procoagulants, bleeding disorders can easily arise. Different causes include vitamin K deficiency, hepatitis, or cirrhosis. And liver disease can also prevent the liver from producing bile, which is needed to absorb fat and vitamin K. The hemophilias are genetically inherited bleeding disorders, and there are three main subcategories of hemophilia. There's hemophilia A, which is the most common type, which is seen in more than 75% of all the cases. And hemophilia A is due to a factor VIII deficiency. Hemophilia B is due to a factor IX deficiency, and hemophilia C is due to a factor XI deficiency. Some of the symptoms that may be seen include prolonged bleeding, especially into the joint cavity, and generalized pain. The treatment consists of injections of genetically engineered factors, which has eliminated the need for plasma transfusion and the risk of contracting hepatitis or HIV. Disseminated intravascular coagulation, or DIC, involves both widespread clotting and severe bleeding. The widespread clotting occurs in intact blood vessels, which blocks blood flow. And the severe bleeding follows because the residual blood is unable to clot because clotting factors are continuously being depleted. And DIC can occur in septicemia, incompatible blood transfusions, or can arise from any complications in pregnancy. The cardiovascular system attempts to minimize the effects of blood loss by reducing the volume of affected blood vessels and also by stepping up the production of the red blood cells. The body can only compensate for so much blood loss. If you lose between 15 and 30% of the blood, the patient will exhibit pallor and whole body weakness. If the patient loses more than 30% of the blood, this can result in potentially fatal severe shock and ultimately death if not treated immediately. As we talk about transfusing red blood cells, there are several ways red blood cells can be transfused. Whole blood transfusions are only used when the blood loss is rapid and substantial, like in the case of a potentially fatal car accident, and the patient is losing a lot of blood and we need to get blood back into the patient as rapidly as possible. Usually what's used are infusions of packed red blood cells, or PRBCs, and these infusions contain contain blood that have red blood cells, but the plasma and the white blood cells are removed. And they're preferred to restore the oxygen carrying capacity systemically throughout the body. Blood banks usually separate donated blood into components, and the shelf life of blood is only about 35 days. That's why the blood banks are constantly asking for participants to donate blood. And human blood groups of donated blood must be determined because the transfusion reactions can be fatal if there are transfusions being made with inappropriate blood types. And the blood typing determines the groups for transfusion. In humans, red blood cell membranes bear many different antigens. Antigens are anything perceived as foreign that can generate an immune response. And the red blood cell antigens specifically are referred to as agglutinogens because they promote agglutination. Mismatched or transfused blood is perceived as a foreign entity and may be agglutinated and destroyed internally, and this could lead to a potentially fatal reaction. Humans have at least 30 naturally occurring red blood cell antigens, and the presence or absence of each of these antigens is used to classify blood cells into different groups. Some blood groups, such as the MNS or Duffy or Kell and Lewis blood groups, are only weak agglutinogens, so therefore these categories are not usually typed unless the patient will need several transfusions. However, the antigens of A, B, O, and Rh blood groups cause the most vigorous transfusion reactions, therefore they are the major groups that are typed. The A, B, and O blood groups are determined based on the presence or absence of two agglutinogens, A and B, on the surface of the red blood cells. People who are classified as having type A blood means that they only have the A agglutinogen present on the surface of their red blood cells. People with type B blood only have the B agglutinogen present on the surface of the red blood cells. People with type AB blood have both the A and the B agglutinogens present. And type O, those people have neither the A nor the B agglutinogens present. Blood may contain preformed anti-A or anti-B antibodies. These are known as agglutinins, and they act as transfused red blood cells with ABO antigens not present on the recipient's red blood cells. Anti-A or anti-B form in the blood at about 2 months of age, and they reach adult levels by about 8 to 10 years of age. Whether somebody has a plus or a negative for their blood type is determined by the presence or absence of the Rh blood groups. The Rh blood groups were originally discovered in the rhesus monkey, hence the name Rh. There are actually 52 named Rh agglutinogens, also known as Rh factors. Type C, D, and E are the most common, and the Rh positive indicates the presence of the D antigen. 85% of Americans are Rh positive. The anti-Rh antibodies are not spontaneously formed in Rh negative individuals, so this can cause complications during pregnancy. Anti-Rh antibodies form if the Rh negative individual receives Rh positive blood, or if the Rh negative mom is carrying a Rh positive fetus. A second exposure to Rh positive blood will result in typical transfusion reactions. As I mentioned, Rh incompatibility can cause many problems during pregnancy and can result in a condition known as hemolytic disease of the newborn, also known as erythroblastosis fetalis. And this occurs in Rh negative moms with Rh positive fetuses. So during the first pregnancy, the Rh negative mom is exposed to the Rh positive blood of the fetus during delivery. The first baby is born healthy, but the mother begins to synthesize the anti-Rh antibodies. If the mother has a second pregnancy, the mom's anti-Rh antibodies cross the placenta and begin to destroy the red blood cells of the Rh positive baby. The baby therefore has to be treated with pre-birth transfusions and exchange transfusions after birth. RhoGAM serum containing anti-Rh can prevent the Rh negative mother from becoming sensitized in the future. Transfusion reactions occur if mismatched blood is infused. The donor cells are essentially attacked by the recipient's plasma agglutinins, and this causes agglutination and clogging of the small vessels in the recipient. And it can also lead to rupture and release of hemoglobin into the bloodstream, which could in turn result in diminished oxygen carrying capability and capacity, a decreased blood flow beyond the blocked vessel, and it could cause hemoglobin in the kidney tubules to accumulate, which can lead to renal failure and ultimately death if not treated. If transfusion reactions occur, some symptoms that may be noticed by the clinician include fever, chills, low blood pressure, rapid heartbeat, nausea, and vomiting. The clinician needs to aim at treating this condition by preventing kidney damage with fluids and diuretics to wash out any hemoglobin that was transfused. Type O blood is known as the universal donor, as people with type O blood do not have A or B antigens present on their red blood cells. Type AB blood is known as the universal recipient, so there are no anti-A or anti-B antibodies present. This can be misleading, as other agglutinogens that cause transfusion reactions must also be considered, as we mentioned previously. And autologous transfusions occur when the patient pre-donates his or her own blood and it's stored and given to that patient if needed down the road. When a patient loses too much blood, it is the main aim of the clinician to restore that blood volume as soon as possible, as death from shock may result from too low of a blood volume. The volume must be immediately replaced with either normal saline or a solution called Ringer solution, which is a multiple electrolyte solution that mimics the plasma electrolyte composition. And the replacement of volume restores adequate circulation but does not replace oxygen carrying capacities of the red blood cells. Diagnostic blood tests are used to examine blood, and they can tell a lot of information about a person's health. They can indicate whether or not there's a low hematocrit presence seen in cases of anemia. You can use blood glucose tests to check if the patient is diabetic or not. And you can also count leukocytes, which may give signs of systemic infection. And microscopic examination of the blood can reveal any variations in size or shape of the red blood cells. If you see an abnormal size or shape or color, this could indicate anemia. If you see the sickling, you could begin to diagnose sickle cell anemia. So diagnostic blood tests do tell a lot. As I mentioned, diagnostic blood tests can inform the clinician of multiple things that may be going on with his or her patient. A differential white blood cell count looks at relative proportions of each white blood cell, and increases in specific white blood cell populations can help with differential diagnosis. The prothrombin time and platelet counts assess the current status of hemostasis. And when you all go to a doctor and you get your blood drawn and you want to look at a complete blood panel to see if there's anything going on systemically, the clinicians will run what's called a CMP, or a comprehensive medical panel. And this is a blood chemistry profile that checks various blood chemical levels, and abnormal results could indicate liver or kidney disorders or other pathologies. But these are key tests in helping the clinician make a confirming diagnosis. And we will conclude our blood discussion by briefly talking about developmental aspects of blood. The picture you all see here indicates the various stages of vascular development in an embryo. The fetal blood cells form in what's called the yolk sac. They can also form in the liver and the spleen. The red bone marrow is the primary hematopoietic area by the 7th month of development. Blood cells develop from the mesenchymal cells called the blood islands. The fetus forms hemoglobin F, which has a higher affinity for oxygen than hemoglobin A, which is formed after birth. And as we mentioned, there are different blood diseases associated with aging. There's the chronic leukemias, there's the anemias, the clotting disorders, and usually these are precipitated by disorders of heart, blood vessels, or the immune system.